Okay. Today's webinar is brought to you by Podometrics, who is a MHPA Silver partner. Podometrics is a longtime supporter of MHPA and our member health plans, so we thank them for organizing today's presentation, Curb Diabetes Complications and Costs. And with that, I'm excited to turn things over to Davidica. Thank you.
Thank you, Patrick. Thanks, everyone, for attending and taking part of your early afternoon to be with us today. Dr. Rothenberg, Gary Rothenberg, and I are excited to be here and won't spend too much time on ourselves. We can kind of drop information on ourselves in throughout today's presentation, but are excited to be here with you and share important information specific to the Medicaid population that you all serve. We know that they're a very important population, and we're excited to gain more traction with Medicaid. I'm sorry, Medicaid. I said Medicare, Medicaid and DSNP as we expand our services throughout the United States. We're going to share some survey information with you today on a survey that we produced last year with over 1,000 Medicaid and dual eligible beneficiaries across the U.S. and thought that you would find that super interesting. Also want to dive into the challenge of diabetic foot ulcers and amputations and how they're impacting your total cost of care, your outcomes, your quality of life for your members, and kind of what they're living with day to day. Also, we'll get into the clinical and financial impact that we found that our solution's been able to provide to our health plan partners, what our solution itself looks like, and how it is kind of a hidden problem out there among health plans in the U.S. today. And then we're excited to go over one specific Medicaid plan's pilot success story with us that we recently finished up. So excited to do that today and share with you. And I'll let my colleague, Dr. Gary Rothenberg, give his own background when he dives in here in a minute. But to let you know a little bit about myself, I've been working with Podometrics for going on 5 years, and I have the privilege of going across the United States and working with all types of at-risk payers, health plans, and even provider groups that take on your all's risk sometimes and help them to really find this member in their population and go after this really much needed complex member who's suffering from a lot of comorbidities, but primarily diabetes that leads to complications with foot care and foot health, and ultimately, unfortunately, but preventable, are amputations. And that's what we're going to talk about a little bit today. But prior to that, I spent 22 years at a regional health plan, integrated provider-sponsored health plan, and worked with these members all the time. But it's funny, it took my experience at Podometrics to kind of really dig in and find out who this member is and how we can help them. So excited to share that with you today. So in 2024, Podometrics did conduct a survey of over 1,000 Medicaid and dual eligible beneficiaries across the U.S. that had type 2 diabetes. And we just asked them a slew of questions. If you're interested in this full survey breakdown, let us know afterwards. We'd be happy to send it to you so you can dig in and see what we asked them. We just pulled out a few of the, I think, pertinent stats around their health plans and their health insurance coverage and things like that. So, you know, I thought it was interesting that 3/4 of them believe that their health plan should offer more digital resources to manage their condition. You know, having said that, I know that you probably already do offer some digital solutions around diabetes, but as we get to know more and more the complexity of this member and that the fact that they typically have 4 or 5 comorbidities going on at once, I think that they do need help managing in between office visits. Again, why 86% of them want their health plans to cover more tools that keep them connected to their care team. And Gary can even speak to a little bit about that, how we found that part of our program and what we do is really tethering that patient and that member back to their care provider, but also having them protected in between those visits so that they're not feeling vulnerable and out there on their own with no help or support in between doctor's visits, because they've got a lot to manage with those doctor visits, seeing so many specialists. As you probably aren't surprised to learn, you know, half of them can't afford healthy food options. They report that. 87% know that proper management can prevent amputations. These are rightfully so, a scared group of people if they've ever had foot complications before. This is a lived experience that they don't want to continue to have over and over again. And 1 in 10 of the ones that we surveyed had already experienced an amputation of some sort, a toe or a foot or partial foot amputation due to their diabetic complications. So really the member is not clueless about what is going on with their feet. They just desperately need help and they need monitoring around it. But again, happy to share this full survey with you. It goes into a lot of mental health. I didn't have time or room to spare here to put up here, but I think it's really interesting, even the mental health aspects of this Medicaid survey that we put together, and happy to share it or to share it with Patrick and team, and they can maybe post it somewhere where you all can access it. So the biggest and most costly problem we're finding in diabetes today is amputation. That's led to amputation. The buildup of an amputation is driven by diabetes, and diabetic foot ulcers are a precursor to lower limb amputations. A third of all diabetes expenditures today are spent on these lower limb amputation complications. I think that if you were to go out in public and just ask randomly what people believe we're spending money on in the healthcare system as it relates to diabetes, I think the first thing they think is, oh, insulin pumps, things like that. I myself had no idea that a third of all diabetes spends comes from that lower limb amputation and the complications. So a diabetic, and in their core, a diabetic patient, someone living with diabetes, has 34% lifetime risk of developing one foot ulcer, right? And once that happens, unfortunately, the recurrence rate is 40 to 50% within the next year that ulcer will recur. And this is something, again, they've lived with it. They know what it's like to go through wound care, which is not fun. And it can be weeks and weeks on end to heal that foot ulcer, only to know that you could have a 50% chance of it happening again. That's where we get involved, and we can tell you about that a little bit later. But to help you find and think about who this member is in your population, if you take an average member living with diabetes, their spend could be around $10,000 to $12,000 on average. But a high-risk diabetic member who's at risk and continues to have complexities around their foot health and complications in diabetic foot wounds can shoot up to about a $40,000 per member per year spend, which, as you know, is quite high. But what we do is, if you were to take a target and look at all of your population, then look at your diabetes population, then look at your high-risk population, it's really only targeted about 5 to 7% of your diabetic population. But remember, this population is responsible for about a third of the total cost of care in diabetes for your program today. We find this over and over again as we work with our health plans. The problem that we've realized is that this member is really buried. They're buried under hundreds and hundreds of codes. When they go into the hospital with the complexity of their state of care, they'll have obesity, they'll have COPD, they'll have heart failure, they'll have peripheral arterial pads, and then they'll have a foot complication, which leads to sepsis. Gary's going to talk a little bit about how complex that patient is, but when you dig into their claims to try to find who they are, they're really buried under almost 250 to 300 codes. We help plans by setting up a tool that they can run against their membership and find who these members are and where they're costing them and how much they're costing them. With the 47% prevalence of diabetes among dual eligible members, and then 9% against all Medicaid members, typically this is where in the presentation I would tell you in this organization how much you're probably spending on this member, but I wasn't able to do so because it's so massive, because of the size of the plans that are part of MHPA. But believe me, it's millions and millions on probably under 100,000 members total. So with that, Podometrics, really quick overview. We've been around since 2011, and Gary's going to talk about how, we didn't invent thermometry and how we scientifically look at finding and getting way, way, way ahead of diabetic foot ulcers and wounds, but we have innovated it and done a lot of work here. So as you can see, we do have a good footprint. We're in 49 states using a cellular connected device that we'll explain to you in a minute here. But we work with the Veterans Administration is a large contracted client of ours, along with various national and regional health plans across the United States. We are now working in all lines of business: commercial, Medicare, Medicaid, D-SNP, you name it. And proud of our growth, and also proud of our clinical background. We put our money where our mouth is, and we try to do continued research and publications, and Gary will talk a little bit about that. But very exciting work that we're always doing, and I'll be excited to share with you later in the presentation, again, this real world examples of a Medicaid and D-SNP plan that we recently were able to wrap up piloting with. So with that, I'm going to turn it over to Gary. I do want to make note, again, if there's any questions, we're happy to take questions throughout the presentation. You don't have to hold them and wait till the end. Just put them in the Q&A, and we'll grab those questions and answer them as we go along.
Thanks, Davidica. Yeah, I'm excited to be with you all this afternoon. My name is Gary Rothenberg. I'm actually a podiatrist. I've been practicing for about 25 years now. I still practice. I am zooming in from Ann Arbor, Michigan. So I practice at the University of Michigan, where I also help run a fellowship in limb preservation. My other hat, of course, that I wear is that I am the medical director for Podometrics. And my relationship with Podometrics goes back about a decade now, when I was part of some of those original clinical trials, which we'll briefly mention, to establish really around the efficacy and the effectiveness of temperature monitoring of feet to prevent complications. But my career has always focused on lower extremity complication prevention in people living with diabetes. And we're also particularly committed to racial inequities in healthcare, healthcare disparities. We understand that those issues, especially around lower extremity amputations, the outcomes are different in different communities, and we really try and help, especially those who are most vulnerable to succumb to these complications. So as Davidica has really kind of alluded to, what we've learned is that the diabetic foot ulcer is really a marker of other comorbidities and the significant advanced status of these patients in terms of their diabetes and complications. As I always say, nobody comes into my clinic with diabetes alone. They all have kidney disease, eye disease, heart disease. And what we find is that when patients develop diabetic foot ulcers, they are at increased risk for exacerbations of these other issues that they're associated with. So again, using an example, if you go to a dialysis center and you peel back the sheets, there are going to be a certain number of those patients on dialysis with diabetic foot ulcers. If you end up going into a hospital and looking at a patient admitted for a diabetic foot infection, their problem list is going to include so much more than just that diabetic foot. So again, this intertwining and the significant cost and quality of life impairment for this member is really, really significant. But on the right-hand side, what you see is that overall overview of the patient with diabetes and some of those statistics that are showing, when you have a diabetic foot ulcer, you are 7 times more likely to be hospitalized for a disease or disorder of the endocrine system. So something else is going on. These patients end up with really high or really low blood sugars. Again, the diabetic foot ulcer is a marker of that. Very common to also be admitted for acute kidney issues. Antibiotics or treatment for diabetic foot infections. We're trying to keep patients out of the hospital, but those antibiotics trip the patient into acute kidney failure. So they end up in the hospital anyway. Again, you can see the statistics, but the most alarming one is that these patients with a diabetic foot ulcer are 30 times more likely to have a lower limb amputation. An open wound is a portal between the outside and the inside world. Leads to infection, especially when there are issues around social determinants of health or other comorbidities that patients struggle with getting the appropriate treatment in a timely manner. And again, we do know that so many of these problems can be intercepted at an early stage, and we can prevent that cascade of events that leads to amputation. So all-cause hospitalizations, again, oh, sorry, diabetic, yeah, all-cause hospitalizations, mortality. These are things that we talk about in terms of the advanced kind of state, or where is this patient on the spectrum of the disease process. And unfortunately, patients with diabetic foot ulcers lean towards the right side of that spectrum. Yeah, we can move on. So I really wanted to emphasize that, as Davidica said, Podometrics, we don't claim to have invented temperature monitoring. We did innovate it to a really unique solution, and we're going to explain how we added kind of a support program around data collection. But what you need to understand is that this is a science that goes back over 50 years. When we recognized, in the famous words of Paul Brand, who's one of the researchers, that the foot will heat up before it breaks down. And if we think about any kind of major disease process, typically that starts with elevated temperatures or a fever. If we develop, the flu or COVID or something like that, the first sign is usually a fever. And the foot does the same thing. Elevated temperatures precede complications, like diabetic foot infections, diabetic foot ulcers, that again lead towards that cascade of amputation. All of our science is really founded on 3 randomized clinical trials, which were NIH funded in the early 2000s, where they added temperature monitoring onto a preventative strategy for diabetic foot ulcer at-risk patients. And these are patients who have already demonstrated risk. So they have had a history of a diabetic foot ulcer, a partial toe or foot amputation. And when you add temperature monitoring, you can reduce diabetic foot ulcer recurrence by 72%. So temperature monitoring is part of a really proven, evidence-based regimen for diabetic foot ulcer prevention, in addition to seeing a foot care specialist routinely, wearing shoes and appropriate inserts, not walking barefoot, checking your feet daily. Those are really the mainstay treatments, but we've come a long way in that we can include technology and really AI and machine learning, which is part of what we do, to help predict when patients may get in trouble. The evidence-based medicine is so sound, and we've contributed to that, but it is now part of clinical practice guidelines as best practices for people with diabetes, to have temperature monitoring included in that prevention strategy for them. So the International Working Group on the Diabetic Foot, the Wound Healing Society, American College of Foot and Ankle Surgeons, in addition to the federal government in terms of AHRQ recommendations, have temperature monitoring in their best practice guidelines for high-risk patients with diabetes to prevent recurrence. Because we know it's quality of life impairing, and we know it's costly to the health plans. So again, our science is very sound. I've been very fortunate to participate in many of the Podometrics clinical trials on the SmartMat. The first one is we proved that this technology is efficacious. So we have a study that we published in Diabetes Care, which we know we can predict 97% of impending diabetic foot ulcers at a lead time of 5 weeks. That's really remarkable in that we have 5 weeks when the foot starts to show signs of inflammation where we can influence change, and we can prevent that cascade of events that leads to inflammation, infection, ulcer, hospitalization, ED visits, amputation, and then all of the quality of life impairment, all of the cost that ensues with that. So imagine, again, that's really, really great data. 97% of wounds we can tell based on inflammation prediction at a lead time, which allows us to, as I say, change destiny for these people. We also have really great data around adherence, and Davidica is going to share with you that plan that we've worked with. But we know, and I think Davidica alluded to this, I always say these patients have the lived experience of healing. It takes oftentimes 6 or 9 months to heal a diabetic foot ulcer. And those patients, if you're working, you might be pulled out of work. You might be a factory worker, and standing at your job all day is not going to allow that wound to heal. So oftentimes, unfortunately, I have to pull people out of work. And that's, of course, very, very significant. But our patients have the lived experience of trying to heal a diabetic foot ulcer or looking down in the shower every morning and seeing toes missing. They don't want to live through that experience again. So when the podometrics nurse calls, they will answer the phone. We have really, really high adherence rates. So what we also wanted to kind of share is across many of our lines of business, you can see on the bottom there that we see significant amputation reduction, significant hospitalization reduction. And our goal is always to look at a 3-to-1 return on investment, or on average around 12,000 dollar savings per member per year. And we tend to see those savings in the very first year that patients or members are enrolled in the program. So our statistics and our outcomes really speak for themselves, and we're proud of that we can have that significant influence on these patients and on the plans in terms of cost reduction. We have a smattering here of different groups that we've worked with. Again, we have worked with all lines of business and focused a lot of our patient care has been in the Medicaid population. You see there, again, it's a busy slide with lots of numbers there, but we've worked with national plans, we work with regional plans. All in the Medicaid line, you can see that there are significant reductions in inpatient visits, significant reductions in amputations, and that translates to better quality of life for the member, but it also results in significant decreased costs for the health plans. We can get into more specifics after, but again, I wanted to really kind of focus on what is our plan and what do we do? How do we help these members really prevent these complications that lead towards amputation? So we use that sound science, and we have innovated that to a very user-friendly kind of form factor. As you can see in the slide, the smart mat is the size of a bath mat, and it has about 1,000 temperature sensors underneath a waterproof cover. And it takes 20 seconds to develop a heat map or a thermogram of the foot, which is what you see in that circle, the orange, yellow, brown kind of outline of those feet. It takes 20 seconds to do that without any Wi-Fi hub or any kind of portal required. You don't have to have a smartphone. The mat itself is connected with a cellular tower that's closest to the member's home. And we have mats, as Diabetic alluded to, in almost every state. In rural areas, we have patients that we're monitoring in Puerto Rico and Guam and faraway places, and we generally don't have problems with cellular connectivity. But that's an advantage because, again, there's no requirement on the patient side. So the member steps on the mat for 20 seconds. It develops that heat map. It is sent through cellular technology to our headquarters in Boston. We are a virtual care company. We have nurses around the country, about over 50 nurses who are monitoring the patients for temperature asymmetry. We use those same protocols that were used in those early clinical trials, and that is 2 consecutive scans with temperature asymmetry of 2.2 degrees Celsius temperature differential, right versus left. So when our nurses note those 2 consecutive scans, we're looking at the middle kind of the slide here. The nurse is going to call Mr. Jones and lead with, "Hey, how are you today? How's everything?" And then they get into a conversation around the temperature elevation that we note in the scan. Essentially, our nurses are going to do a telephonic history and physical. They're going to ask questions. They're going to incorporate a caregiver or a significant other who may be in the home to help them evaluate their foot, especially our patients. Again, they have visual impairment, they may be obese, they have impaired mobility issues, they can't see the bottom of their foot. So if there is somebody in the home that can help the nurse and the patient go through that kind of list of questions that we may have based on the temperature elevation, we incorporate those caregivers as well. What we've learned is that providers, in between their visits with these high-risk patients, they really appreciate us having eyes and ears on the patients for them. And of course, the patients appreciate that as well. But what our providers need and want to know is things that are actionable, things that they are unaware of, and things that they can intervene on. So we will, on occasion, when we hear something like the member will say, I have a red spot or a blister underneath my big toe. Thank you for calling. We do engage the provider to make them aware of that. And then they can make the decision to see the patient, do some sort of intervention that may be required. And so a lot of times our nurses are recommending simple, low-cost solutions to help resolve that inflammation without ever having the member have to come into the clinic also. Things like staying off of their feet, continuing to scan, wearing appropriate shoes, elevation, those kind of very simple things which can help resolve the inflammation. The next slide, Davidica. Yeah, we want to really kind of make the difference between adherence and engagement. When we think of adherence, we think of our members stepping on the mat every day. And that's what we really want them to do. And our nurses will encourage them to make it a habit. So it's, do you want to do it when you brush your teeth? Literally put it in front of the sink and do it while you're brushing the teeth. It takes 20 seconds. Do you associate it with taking your morning meds? Whatever is very convenient for the member. Our nurses are trained to kind of work with them to find out how can we establish this 20-second per day habit, which can really help you and help the provider avoid these complications. So what we see, again, probably because these patients have the lived experience, is that the patients are really good about stepping on the mat every day. We have about 3/4 of the patients are going to actively scan at least 4 times per month. We do know that we want them to do it every day, but there is significant value in doing it even several times per week, because we get that information and on our different call types, and there are a variety of different call types that we have, but we gain that information and gather that information for the provider in between the visits. And we know about 70% of our members continue scanning after a year being in the program. And when we survey them and we ask them, do you want to continue? Their answer is yes, because they know that we have eyes and ears on them. We also talk about engagement, and that is, will a member pick up the phone when the podometrics nurse calls? And you may be surprised. It's even in our Medicaid population, we have really high engagement rates. Our statistics show 73% call completion rate. We call, the member is going to pick up 73% of the time. Our members pick up on that first call, which is really, really astounding to us. But we have that built relationship with this high-risk patient, and they know that we're there to support them. We have different types of calls. They're listed there. That's our enrollment call. Of course, that's the first time we initiate, establish a relationship with the patient. Our onboarding call, where the nurse will talk them through the value of the program, as well as make sure that they successfully take their first scan with them. We have wellness calls. We touch base with the member monthly, even if we don't see elevation of scans, so that they know that we're engaged and involved in their healthcare. And then, of course, those monitoring calls when we do see temperature asymmetry. So we really do have very high adherence and engagement, which I think speaks to the success of the program. Next slide. Yeah, Davidica, do you want to take over here? Oh, you're on mute.
Thanks, Gary.
Yeah.
Sure, we'll do. Just wanted to kind of walk through the program workflow of how the program actually works. And I meant to say earlier, because sometimes you might be thinking now this is a device, but it's a virtual care. We really are, I would say with our health plan clients, we're what they refer to as a clinical program partner. So with most health plans, we will roll up somehow through care management, the CMO's office, strategy under case or care management and population health, and sit there as a vendor, but really a clinical program partner for their case management, disease management under, it could be broadly sitting or under diabetes specifically. But then when that happens is, again, like I said, we work with a plan to help them identify who their targeted members are that we would deem qualified for the program or eligible. And really the core target member that we go after and work with the plan on is someone who's already had one diabetic foot ulcer within the last 24 months. Because again, they're sitting in that very volatile recurrence state where it's likely to happen again. And we can, and that's who we target first to bring into the program. So we work with the plan. They'll give us an eligibility file, and that's when we start our program enrollment, where the Smart Mat is an FDA cleared mat that does require a prescription. We work with our plans, and they'll go in and identify the member's primary care and any podiatrist that they've seen. Because typically we'll want a podiatrist to be following the patient, and in many cases we'll help them find an in-network podiatrist, or the plan can help them find one if they're not being followed. But in most cases they are, because they've had a wound before. And unless they're very rural, most primary care physicians don't follow for diabetic foot complications and wounds. So once we get the provider involved and complete the prescription process, then we do that enrollment process with the member. But again, the mat goes to the member's home in a box with a sticker on the outside that says, here's your mat, brought to you by XYZ plan. Open up and you're ready to go. It comes charged. They just simply turn it around, push a power button, and in about 20 seconds, it catches the nearest cell signal and they can start scanning. The beauty of the mat is they can stand on the mat, or if they have mobility issues, they can actually sit and just place about 4 to 5 pounds of pressure on the mat, and it's going to get the thermometry reading. And it is specific to that member. If the member's cat sits on it or their baby crawls on top of it, we'll know that it's not the member scanning, and we will reach out to say, hey, something's going on with your mat. But we know that member's template, and we build a template like is what is behind me, and we know what their baseline of their foot temperature normally looks like. So they're activated, they're off to scanning. We coach them to scan daily. Some of them scan, 3 to 4 times a week. It just depends what their habits are and what they're doing in their routine life. Again, once they're in that stage 3 and 4 is pretty much where the member lives all the time. They're scanning daily. And we like to tell them, hey, really, no news is good news from us. We're not going to bug you and call you. But when we do call you or text you, if that's your preferred, communication form, it's because we see something on your scans and we'd like to talk to you about it. So we do get that about that 73% engagement rate of members are likely to pick up our phone call or respond to our text when we reach out, because they know we're reaching out because we have something to share with them. So then that ongoing measurement or monitoring, is happening. And then we'll do the closed loop. We'll go back and circle around and involve the provider when necessary. It's not always necessary, but it is if it's a persistent inflammation, and we want the provider, like Gary alluded to have his or her eyes on the patient. So we're doing all of this. The lovely thing is that we've built a care integration program as well that I can talk about in a minute, that we're sending these alerts and this program information back to the health plan as well. And I'll talk about with the one case study with the plan we piloted with it. They helped us really build out an integrated program where they were telling us what their needs were to collect and identify member information that we shared back with them on a daily or monthly routine, depending on how they needed it. But so this is all information that's a big circular loop. And if we send the member for an escalated, doctor visit, most of the times it can be handled there in the office, low cost intervention. They're back home and monitoring again. And again, ask any questions. We're not shy to answer anything. We'd love to be put on the spot. This is just a little bit about program. Member and provider feedback. Love that we collaborate with plans. We can customize surveys, but we do survey our members. With a health plan member, once they've been on and scanning for about 3 months is when we send a survey to the member to make sure, see what their satisfaction is with the plan, with the program, with the mat itself, the device, and our nursing program and how we're working with them. It's only, 5 or 6 questions. And then we will customize the survey to a health plan member if the health plan would like us to. But we do include in the survey a CAPS-like question that basically asks the member, are you more satisfied with your health plan because they've brought to you this program? And with that, it's, so 8.9 out of 10 is how our members across the board, this is collectively with all of our clients, are scoring that 9 out of 10 members are saying that they're more satisfied with their health plan because the health plan enrolled them in this program. So you can see here some of the quotes. It's all about really that comfort and knowing that somebody's watching their feet, because half the time they can't see their feet or feel their feet. And just knowing that there's that comfort level of that presence of somebody's monitoring them that we get over and over again. On provider satisfaction, again, high satisfaction rates. A lot of times, and we work with some integrated delivery systems that are at risk through their payer arrangement, or they're integrated with the health plan, and they work really closely with their health plans. And in those cases, again, they recognize that they like this tether, that there's somebody watching their patients while they can't get their, while they can't see them. But then they're also love the fact that we can triage a patient and help them to reduce that inflammation remotely, where they don't have to go to the doctor as often. And that helps the doctors' workflows and their provider satisfaction, quite frankly, with their staffing. So they have high satisfaction rates as well there. I want to talk to you about, this is a Medicaid plan success with Podometrics. So we recently finished all the validated outcomes measuring of a 12-month pilot study we did with a Southwest area Medicaid and duals plan. They had a significant number of members with diabetes. In fact, they had a 49% prevalence in their duals population of 49% of their duals population had diabetes. And then again, within that population, I don't know offhand, it could have been 7 to 9% of them had already had one foot wound and qualified for the program. So we launched a 12-month program there. We targeted with the plan, the complex members that had diabetes as a first, marker. And second, were at risk of diabetic foot ulcers. They either already had one, or they had a lot of complications that we felt like they could be leading to their first one. So we went in with the plan, identified those members, and that's who they targeted as the eligible population for enrollment. The primary goal of the 12-month study was to prevent complications from those foot ulcers specifically, to reduce the number of amputations that were going on, and to reduce hospital stays. And reduce total overall costs. But those were the key measures that we were tracking and looking at as time went on. Just to tell you a little bit about the medical and social history demographics of this core membership. Again, this is a Medicaid and a duals population. All told, we had almost 800 participants throughout really an 18-month period, but we took the first 12 months and just clinically validated the outcomes there. So this is almost 24-month period with 792, but for purposes of the study, I think we looked at about 400 of them. So again, average age, high prevalence, you can see almost 80% have neuropathy, more than 80% have vascular complications. Now this is self-reported during our intake, our enrollment call. It's also anything they report as the program's going on and our nurses are talking to them. 70%, we're using some kind of mobility aid, again, probably because they're unstable on their feet, as a standard and as a baseline. And then almost 60% had reported. We do ask them about whether or not they've had a fall in the last year and whether any of their providers knew about it, and how they were feeling stability-wise. And I want you to make note of that. As we come up, we do have a solution. We've got some capabilities now to address more than foot thermometry and the temperature reading. We're going to talk in a minute here about fall risk, because we know that's important to a lot of plans as well. So what we found is that ongoing engagement with these touch points where we're collecting this information, subjective information, really the plan just glommed onto it. The plan was like, you're collecting such great information we're not getting from our members. Could you work with us to support us and get that information back to us? So really out of this pilot, we as a company chose to create and develop a care management support tool or model, if you will, where we're sending over daily feeds to their case managers. It goes directly to the case managers or director at the case management level, so they can distribute that information to the case managers, because these members are already in case management or disease management for the most part. They can use it to outreach to members proactively, or they can decide if it's historical information they just want to put in the member's file, so that the next time they talk to the member, they can address that issue or that question or concern. So really proud of this work and our ability to really collaborate with the plan and get them the information that they need and want going forward at the member level. Some of the outcomes of this actual study, again, 12 months of validated claims and outcomes measurement showed a 30% reduction in inpatient stays, a 50% plus reduction in amputations. So a 10% reduction in ER visits. And then something that plans have brought up to us is wanting to look at the cost of these really expensive skin substitutes. And in this case, we went in and were able to look at claims and discovered a 60% reduction in the use of skin substitutes. This membership, even though, admittedly, the plan even said it's a hard to engage membership, adherence wise, we found them engaging or adhering and scanning on average 3 times a week. Engagement wise, picking up our phone and engaging with us when we call, our company average across all lines of business, honestly, is in that 75% range. On the dual eligibles, we're still at about a 68% engagement rate, where on a Medicare Advantage member, we're almost at 90% engagement rate. So you can see where there's diverse engagement rates based on the line of business. But still, plan was very happy with a high 60s, low 70s engagement rate with this member. We did ask the members how satisfied they were with their plan because of the program, and 93% believed that it enhanced their experience with their health plan to be able to access this program through them. And the 92% were highly satisfied with our program in general. The other thing to comment here is this is a concurrent study. So what we did was we took their entire eligibility file, and not everybody is going to be able to join or chooses not to, or maybe we can't get a hold of them, or the plan can't. So in that case, we did a concurrent study, and we had a control group. We took the members that did not or could not enroll versus the members who did enroll. And the control group had 1,900 members in that group. So we took the 1,900 eligible, same population, but didn't enroll versus the membership that did enroll. And that's what we did the study and the concurrent review on. So we reviewed members who were not in the program, still covered with the plan, and the members who did enroll in the program. Also want to point out that we did see overall a 20% total cost of care savings rate in this population for this plan. Representing about $1.2 million in savings over the 12-month period. Going forward, what the program's going to look like, we are expanding with the program. We've made the decision at their request to incorporate non-medical screening questions. So I think with the comfort that the member is talking to us and will talk to us, the plan specifically asking us to start doing some non-medical screening with their members when we have access to them around housing and food insecurity and financial concerns. So that's something we'll be adding to the program as we go forward, and we can then report that back to the plan. We are using the deployment of a new predictive model tool that we've created with our actuaries to identify that the plan saw such success in this really high-risk group that they did want to look at a moderate risk group who've not yet had their first diabetic foot ulcer, and to broaden the program so that we can include both secondary prevention, and then this would be a primary prevention model. And we're really excited about this predictive model. Spent a lot of time and effort on it. I would say that's one of the most asked questions when we're meeting with the medical team or medical director's team or CMO team at a health plan is, love the idea of the secondary prevention. What do we have to do to go to broader and to get to primary prevention? And so we feel really confident now that we've got a way to identify those members and look at that subgroup of diabetes members as well. And then given the level of high comorbidities in this population, we are going to be exploring supporting both fall risk prevention and heart failure with this program partner and this client. We're going to have those new opportunities and capabilities because we are going into a new phase of our SmartMat Plus. What Gary just explained to you, it's still the same patient. It's the same patient who's suffering from diabetes and the effects of it, and lower extremity complications, but then also probably has immobility problems. As you remember, I said that I think this population, 68, almost 70% of them, almost 60% of them had had a fall in the last year. So that tells us that a really high percentage of our, what we call diabetic foot ulcer patients would be qualified to prevent fall risk with. So, and I'll tell you about that in just a minute. So that, and then I would say the other most asked question I get from medical teams at health plans is, if you can grab my member and get their attention for 20 seconds a day, what else can you get me in that 20 seconds with their feet? And so we are evolving to do a fall risk mobility or stability monitoring and identification along with weight, which will help us with heart failure. So those are in the next version. I think I do have that here next to go over. So, but any questions about this actual pilot and this study, we're happy to answer those for you. So we will be at the end of this year launching at no additional program cost to any of our clients, current or future. We just want to get better at what we do and help expand the complexity of what we do and help our health plans with this complex member. So our SmartMat will look a little bit different, be a little bit more compact. On top of the foot temperature measurement, it's going to have a stability measurement. And within about 10 scans, we'll be able to get a baseline of the patient's stability baseline. So we'll know what they look at baseline, and we'll be able to tell from scan to scan if their baseline, if their mobility is off, their center of gravity and things like that. So we're adding fall risk prevention as a capability and measure to the SmartMat. We're also adding a weight measurement for heart failure monitoring. The other thing that we're offering is, feedback from our members was that sometimes they wanted some kind of instant feedback. We do send them a monthly report that shows their scans and tells them, it's kind of like a report card, how many times they scanned, what their scans looked like. They love getting those, but you do have a percentage of members that want something instant. So we are building out a detachable controller. They can stay on the mat or they can set it on the countertop, but it will give them feedback immediately on their scan, how it looks. It'll be a little bit of a delayed response because we always want to look at the scan first to see from day to day if there's any changes and if we need to reach out to them. But it just gives them that immediate gratification of, oh, I scanned and this is kind of what things are looking like. So we're excited to launch our new SmartMat Plus in the second half of 2025. So in summary, I just want to summarize things here. You've been a great audience today. Would love to take, again, any questions that you have. Bring them on. Gary and I love that. But again, the overall problem with a third of all diabetic expenditures going towards this member that's a high-risk member suffering from diabetes and lower limb complications repeatedly can be quite costly for a health plan. We know that, and we work with our plans to help identify those members. And really, that's sometimes the best next step is to look at your prevalence and look at what your membership looks like. And if there's any way we could be a good clinical partner for you and help you with that membership. We love what we do, and we do know that we're saving lives and limbs. In the hour that we're on today, 17 members will have a limb amputated. 17, not 17 of your members, 17 people across the United States will have limb amputations. That's how frequent they are. And for us to know that they're absolutely preventable and to partner and collaborate with plans excites us to be able to give these people a better quality of life, longevity, and satisfaction with their life, because they have a lot going on. And if we can relieve them of the stress, the day-to-day stress of not knowing what's going on with their feet because they can't see them or feel them, then we're doing that and excited to partner with health plans to do that as well. So thank you. Want to ask if you have any questions and see if Patrick has it. Yeah.
Yeah, Davidica, we do. We got a few here. And folks, keep in mind, you can type questions in as we go over the these I'm about to address. So we still have time. Okay. All right. Question number one. Let's see here. All right. Who is the best candidate for this program and who would not be a good candidate?
You want me to do that one, Davidica?
Yeah, sure.
It's a great question. So, our classic patient that we really know that we can help is the patient with diabetes who's already demonstrated risk. So, a member who has had a diabetic foot ulcer, who's had a partial foot amputation, partial toe amputation, dialysis patients, we know that they are at very high risk. Patients with Charcot-arthropathy, a very unique form of arthritis that can affect patients with diabetes and neuropathy where the foot actually kind of collapses. Those are our typical high-risk patients. As Davidica mentioned, we can go, deviate away from those patients too to more primary prevention as well. But sometimes, again, it's really, we like to partner with the plans. We like to partner with the providers because they know these members. They know, are they at risk? Are they right on the cusp of developing those complications? So we don't love to have hard and fast criteria, but those are general criteria around members who we know can benefit from it based on our experience, based on the evidence-based medicine. It is an FDA cleared device. So the question about contraindication, we really do know that patients who are non-ambulatory, who don't walk, there may be an indication for the SmartMap, but oftentimes they're more at risk for developing pressure ulcers as opposed to diabetic foot ulcers. And that etiology is a little bit different. And we don't always see inflammation precede pressure ulcers. So I would say non-ambulatory patients are probably not the best candidates as a clinician, as a provider. The only contraindication to standing on the mat is an open wound. So there should be intact skin. And again, if a patient does have a wound on the right foot, for example, we really would love them, and we think that they're ideal candidates because as a podiatrist, when I'm trying to heal a wound on the right foot, I'm telling them to stay off the right foot. What do we think is happening to the left foot? That left foot really does need attention to make sure that it does not develop complications during that period. So, and as Davidica said, these members who only have one foot that is eligible for scanning, or unfortunately, if you already have had a high level amputation like a below knee or an above knee amputation, those patients can also be candidates. And our nurses will encourage them, as Davidica mentioned, to sit to scan, that they don't have to, be a flamingo and try and do it on one foot, that they should be encouraged to sit to scan. So great question. I hope I answered that.
Mm-hmm.
Absolutely. Okay. Let's see here. We have another one. How long does it take to implement the program?
Oh, I can take that. That's a great question. I should have brought that up sooner. Honestly, it's a low lift. That's coming from the health plan I came from, working with long implementation times. This is a low lift implementation. Honestly, from contract execution to launch and having the first mat go out the door, it's 45 days. Because we do a lot of pre-work. It's around grabbing the data from the plan and being able to get that eligibility file set up. But again, it's pretty simple. We've been doing this now for a while and have it down. And then really, a step we do like to take that could take several weeks to get managed is co-branding some member collateral and provider collateral so that the members are comfortable and see the plan's logo on the outreach information, a postcard, or like I said, a sticker on the outside of the box. It's stuff like that that goes through some branding and compliance. Other than that, those are the two lifts from the health plan, honestly. And then working with their care management team to train them on the program in case those case managers have questions. So again, all of that can be done, and it is done over and over again by us and our partners in about 45 days.
Perfect. It looks like we're running up on time but we have one more question. When do you start to see an ROI?
Oh, that's a great question. The study that I went over was a 12-month, but we actually had 6-month results as well. So you'll absolutely see an ROI and outcomes and measurable at 12 months, but we honestly see them at 6 months. That's our first measuring point, and then we'll go in at 6 months. With some claims lag. So we go in honestly at about 9 months to look at 6 months worth of claims and get our initial first 6 months of outcomes, and then we'll validate it and do it again at 12 months and go on from there. But you'll definitely see it in the plan year for sure. But you can see it in every plan we've done a study with and tracked measures on. We've been able to see outcomes within the first 6 months.
Okay, perfect. Okay, I think we'll leave it there. Just before I give the floor back to Davidica and Gary, I just want to thank everyone for joining us this afternoon. And to remind you about MHPA 25, September 10th through the 12th in Kansas City. This is the last week for call for presentations. Let us know if you're interested in that. And again, I just can't thank Davidica and Gary and the team at Podimetrics. They've just been great supporters of MHPA, and as I mentioned, our member plan. So thank you so much to both of you and Podimetrics as a whole.
Thank you, Patrick. We appreciate being here this afternoon and everyone's time, and look forward to seeing you in the fall.
Thanks very much.
Yeah, don't hesitate to reach out with any questions.
All right. And then feel free to reach out to MHPA if you'd like us to connect you with the presenters. Obviously, you have their emails right there. Thank you, guys. Have a great afternoon.
Bye.
Bye-bye.